So welcome everybody and thank you for joining today. My name is Isabel. I'm the Community Digital Transformation Lead for London. Just to let you know that this session is being recorded and that you've joined the Community Services Dataset onboarding Q&A session. So I'm here with my colleague Ucr and we're part of the London Digital Community Health Services Programme, and that's being delivered together with our ICS community and digital leads, and I think quite a few of them are here today as well, so thanks very much for joining. We're also joined by national colleagues that you'll meet in a moment. So Ucr, if you could just pop up the agenda for today. That's it. Okay, so I'm going to give a quick update on our regional progress. We'll then listen to Steve talking. He's not able to join us today, but he did send a little video, so hopefully that will work. We'll then hear from Rob and Freddie, the data analytics team in the national team, and they'll give us a national update. And then Giles will show us the newly flashy new Csds Dashboard. So that will be quite exciting to see. And then Dan will deliver the main part of this, which is the live demo of step by step how to register and submit, and also indicating some support and guidance. And then we'll have a Q&A session. So any questions you have, you've got the ears of the national team here. So absolutely don't hold back and put questions in the chat. And if we don't get to them, we will respond to them offline. Okay, so that's the agenda and you can take that down now. Thanks very much, Ucr. A lot of fantastic work has been achieved over the last year with the Community Services Dataset, and you'll see all that in a moment. And that's only been possible because of the engagement from our ICS community and digital leads, but also really importantly from our community provider organisations, and actually the individuals within the provider organisations and those that really get it and see the value that working on this together can bring locally, regionally and nationally. And it is a long road. Primary and secondary care went through the same process, and there's now some excellent information about those services that's useful for everyone using it locally. And now it's our turn in community settings. So the work we've done over the last year has really taken off. We've started to see the outputs from that, as you'll see and hear in a moment from our national colleagues. And from the community provider data submitted to CSDS over the last year, we're starting to really get that visibility and understanding of community services in London. Now we do know and we have heard about the challenges and how clunky it is, and how it can seem like you're inputting your data and into and using resource to submit data into a black hole, but that's all changing now, and that is continuing to change, and that's all thanks to that feedback that we're getting from providers and us getting a better understanding of the challenges faced by organisations like yours, and also understanding the resources, challenges, the processes, the systems that you use, and how they may or may not support submitting to CSDS. So this feedback really has helped in developing a much more fit for purpose CSDS that will be useful on so many levels, leading to obviously improved patient care, which is why we all do what we do. And the journey continues, but it is getting easier. So just a little bit of background on the regional work so far. The Digital Community Health Services Programme for London kicked off exactly a year ago, and one of the key work streams was and still is data and getting that visibility of community services in London. And we did hold a similar Q&A session last year with urgent community response providers, and once they registered, we very quickly started to see that data flow. And we didn't focus on data quality initially, we just wanted to see that data start flowing, because just being able to see that really enables the data teams to adjust accordingly. And but what we can say is that all of London UCR community providers are now onboarded. There are just 5 providers in the rest of England that still need to onboard. And hot off the press, the 3 UCR metrics were published for the first time on the 16th of June, so just a few days ago, and that was based on April primary CSDS submissions. And UCR data will be published monthly from now on, and from July there'll be a Power BI tool that'll be released containing metrics on all aspects of UCR, and all that data is taken from CSDS, Microsoft BI, Power BI. And from that data, we can see that I'm very pleased to report that our UCR performance in London is one of the best in England, and with North West London reporting the highest number of care contacts, higher than any other ICS. So that's the power of the data, and you'll see a lot more in a moment. You may also have seen the HSJ article covering the publication and highlighting the providers with low reported UCR referrals, and none of these, I can happily say, are in London. And we can send along that article when we send the slides out. So as part of the next phase of the work, we validated the London Community Provider List with our community and digital ICS leads to update that list that's held nationally. And this is now the single version of the truth and ensures that all of our NHS funded community services are represented. So we now have that fully validated list, which we continuously update to make sure that it represents the services that we've got. So that's the background. I would like to acknowledge the hard work that's been done locally, regionally and nationally within a really challenging context, and I know you've all been through that. This has got us to where we are today, and it'll lead us to achieving so much more this year. And in a moment, you'll see that vast support and guidance that's available to you on a one-to-one, but also in webinars and just resources that you can draw on. So that's it from me, except to say that we are very lucky to have two clinical SROs leading the London Digital Community Health Services programme, and that's the London Chief Nursing Information Officer Sarah Newcomb, and also Steve Toland, who's the London Allied Health Professional Lead. And so I'm going to show you a message from Steve now. You may need to turn your volume up, but if you do struggle to hear, we'll share this with you alongside the slides as well. So I'm just going to see if I can share this now with you. And if I can just ask you to put yourselves on mute, I can just hear a bit of background noise. It'll be helpful for everyone. Thank you.
Hi, I'm Steve Toland. I'm the London Region Chief AHP for Energy. Allied health professionals, AHPs, are 14 professions, third largest.
Oops, sorry.
Course, physios, OT, speech and language, and others. And the reason why I'm speaking to you is to provide clinical endorsement services data set. So you all will have heard and will know probably better than me that we often talk about the absence of community data and the impact that has in terms of planning. What we're increasingly hearing from community services and clinicians working in that setting is the urgent need to be able to describe community services in their own right, and not just be describing the impact of community services on acute pathways. And that's an opportunity that I think is provided from the community services data set. But additionally, the opportunity to help us describe and define need and not just demand for services, something that's incredibly important from my perspective in terms of looking at the quality and safety of services, but also to aid us in terms of workforce planning and understanding the resources that we need to do the things that we need to for Londoners. So, as I said, I just wanted to add my clinical voice to this conversation as a sponsor and advocate for the regional programme, and I hope you find the rest of it.
Okay, I'm not quite sure what happened there. All right, so that was the message from Steve. I'm going to pass the slide over to you with the slides, so you'll be able to hear it in your own with your own headsets, and it will be a lot clearer. So hopefully that was useful. I'm going to pass over now to Rob and Freddie, who will give us the national CSDS update. So over to you, Rob.
Great, thanks very much, Isabel, and yeah, good afternoon everyone. So my name is Rob Massam, and my colleague Freddie and I, so we work in NHS England's Discharge and Community Services programme as part of the data and analytics team. So one of the things we're involved with is improving the community health services data set, so working really closely in partnership with colleagues at NHS Digital, you know, as well as our regional colleagues as well. And just wanting to reiterate what Isabel said at the start. It has been a long road up to this point, but we really appreciate all the work that you're doing to improve community services data. So thank you. So what Freddie and I want to kind of cover in this first section, probably three main things. We want to give a really quick update in terms of, you know, what is CSDS, and my colleague Dan Corley later in the call is going to go into a bit more detail about the data set. But the key thing we wanted to do at this point is give a bit of an update in terms of some of the key developments that have been happening with the data set over the past year, but also to convey how CSDS can be useful to you and your work. And then finally, we do want to cover off what some of the plans are for this year as well. And then, as Isabel said, we've got some time for questions at the end. So just to check as well, I can move, if I move through the slides, someone's done it for me. Brilliant, thank you very much. So what is CSDS? Just as a bit of a recap, so CSDS, it's a patient level secondary uses data set. So for people who are in contact with publicly funded community services, and as it's a secondary uses data set, so it reuses clinical and operational data for purposes other than direct patient care. And this is the main data set we have for the community sector. It was initially implemented in April 2017 and has evolved from the children and young people's data set. So that's all I'm going to say about Siesta at the moment, but as I said, Dan and colleagues will come back to that. So we can move on to the next slide, please. Thank you very much. So just in terms of key developments over the last year, so as mentioned by Isabel at the start, for the very first time, we've been able to map the community sector and identify who are community health services providers, and I think that's been really fundamental. We've not had that before, and really grateful to Isabel and kind of colleagues on this call for your help in validating that list. And we've also really tried to improve coverage to the data set, which you know, is an ongoing kind of challenge and ongoing opportunity as well. So over the last year, we have ensured that we've now got 96% of urgent community response providers submitting to the data set, which is a big achievement and will allow us to track, and as Isabel said, going to be able to track for the very first time the new Ucr 2-hour crisis response standards. That's brilliant news. We've also worked with NHS Digital to develop a dashboard for UCR. So it's not just about saying, you know, please submit to CSDS. We really want you to be able to access and use the data so it's useful for you too. We've also developed a new data quality dashboard and toolkit, which you can use to help and give a sense of you know, how providers are doing when it comes to data quality. I'm sure my colleague Dan and maybe Giles will touch on that later in the call too. We've also reduced the time to access data in CSDS. So this has been based on the feedback we've received from you. Like last year, this has been an issue. So historically, there's been about a 3-month lag between a submission window and kind of opening and then being able to access the data. So we've shortened that. So we've now got a primary window, which is 2 weeks, but providers still have the chance to come back and refresh the data. We've also been looking at innovative ways in which we can access the data, and so we've been looking at how we can directly extract data. And again, it's still at a stage, it's a feasibility study, but we're really trying to explore what can we do to minimize burden on providers. So that's just a bit of a summary in terms of the key developments over the last year. In terms of the benefits of CSDS, so there are many, and I think the key one, it will support insights in terms of service provision in the community. And as we develop more use cases moving forward, and UCR is a great example of one policy area and one kind of national standard, which we'll be able to monitor via CSDS. There's also the potential to link CSDS to other data sets. That's something else that we're looking at. And the data set also has the potential to help reduce variation and the opportunities to improve care across the system. The blue box here is really our vision in terms of what we're looking to do. So it's trying to ensure that data about community health services should enable national teams, local systems to easily understand what works, monitor performance and outcomes, and identify variation and actionable insights for improved care and services. I think the point's already been made, but I think there's also benefits too in terms of building the case for why we need more investment in community health services, which historically has not received the attention it deserves. So the data that you provide is helping us at a national level as well build that case for more investment. And before I hand over to my colleague Freddie, and I know I'm kind of aware of time too, I did want to kind of acknowledge there are still some challenges, and I'm sure you'll share with. Really keen to hear from you too as well around the challenges that have been reported to you too and that you experience. But we're aware that coverage is still a challenge. So we've got, as at March, 168 providers submitting to CSDS, which is a vast improvement on where we were at. But we know from that mapping exercise that there are over 1,000 community health services providers. So there's still some work to improve coverage, and we really appreciate your support in changing that, and the support is there as well to work with you to improve that coverage. That we know there's still issues around data quality, issues around how complete the data is. So my colleague Freddie is going to talk about some of the things we're doing this year to improve that. And then finally, we're really keen to make sure we improve how data is visualized and presented. So it's not just about, as Isabel said, data being submitted and going to a black hole. That's a challenge. I think we've made some good progress on that, and colleague Giles is going to showcase this really flashy Ucr Dashboard, which is brilliant and is a starting point, but there's a lot to do to improve the visualization too. So thank you again for everything you're doing. We really do appreciate it. We really want to build on the really good progress that's made last year. So I'll hand over to my colleague Freddie at this point. Thanks very much.
Thank you. Hello everybody. So just following on from what Rob was talking about, the slide is about the areas of focus between ourselves and NHS Digital really going to work together, and obviously with the support of all of you to really focus on improving CSDS this year. So there's three key objectives. One, Rob's already kind of indicated, is about trying to increase the coverage. So, supporting more providers to onboard and to submit. And you can see here in these four smaller circles, these are the policy areas and the provider types that we're really keen, are involved and are submitting. Obviously, phase 4 providers, the £1 million plus contracts are on there, and they are a really key area of focus. So there is, as Rob said, a lot of resources, a lot of tools and support available, which NHS Digital colleagues will go on to talk about later to help you to do that. The second area is around improving data quality, so as well as coverage, making sure that the data that is submitted is as good quality as it can be, and part of that is about raising awareness of the Data Quality Maturity Index, which I'll come on to in a minute. And then the kind of third key area is around, again, Rob mentioned, making sure that we're reporting the data submitted in a visual way, a more accessible way. So just moving to my last slide here, this is just in a bit more detail thinking about what are we going to be doing, what's new, what's going to be coming down the track this year that will be useful to you, we very much hope. So one here is around launching a dashboard for the Data Quality Maturity Index, and we know this is quite a new kind of area, maybe new to some of you. It is what the DQMI is about, is trying to really provide more information about data quality to providers. And there is a DQMI dashboard for all sorts of data sets, including CSDS, but what's going to be developed and what is being developed currently is one specifically for MSK and UCR. to enable yourselves and others to really look at what's contributing to the data quality associated with those services. So we hope that's really helpful. And then the second two areas are around that point about making data more accessible to you, presenting that back. So one is, again, Rob mentioned developing a dashboard that allows you to access and to understand the monthly data that is currently published, but allowing you to interact with that more in a dashboard format. So that's something that's been underway, and there's going to be further consultation and engagement to make sure that really contains the information that is most useful and what you want to see. And then the final one, another dashboards. We are doing other things, not just dashboards, but these are the kind of key new things that I thought would be interesting. So the final one is, again, Rob mentioned a Ucr dashboard. It's currently on Futures, so you can look at it there, but it will be launched beyond that. So those are some of the key areas. Rob, is there anything else that you wanted to add?
Yeah, I think that really covers it. Freddie, keep in. Thank you.
Thanks very much, both. And just picking up on Kieran's question, if this identifies variation and is national, is it to be used as a benchmarking tool? Now, I'm presuming, Kieran, that what you're meaning is, will there be a stick beating you over the head if you complete this? Is that where you're coming from?
Kind of, yeah, basically, but also just will it be available across the board for all types of community services, and therefore for community providers such as ourselves, can we benchmark against similar organisations just to ensure that we are, on track, or where we can make improvements?
Absolutely, yeah. I'll let Rob. Do you want to add anything to what you've written in the chat?
Yeah, and I think it's definitely there is a potential for benchmarking, but definitely not in the sense of kind of the stick, but more in the sense of actually comparing to other regions, or as you said, Kieran, as well, to kind of looking at across different services as well. And I'm sure when Giles comes on to talk through the Ucr dashboard, you'll see some of the. I know that he's just focused on Ucr, but in terms of the other work we're looking to do on that wider dashboard for Csds, we're really keen that there's possibilities to do that for other areas as well, and other service areas, not just Ucr.
Yeah, and also locally, the aim is to make it, you be able to benchmark across your system as well, isn't it?
Yeah, completely.
Yeah. Okay, great. Thank you very much for that. Giles, will pass over to you now and show us our the Csds dashboard, please.
Hi there. Let me just share my screen.
Thank you. Yeah.
Okay, hopefully you can see that.
Yeah.
So I recognise a few names on the list, but for those who don't know me, I shall introduce myself. I'm Giles Foster, and I'm one of the analytical section heads, currently working in NHS Digital in the community and mental health analysis team, mainly on community itself, but I also look after Mental Health Act and various other things. So I'm briefly going to give a quick demo on the Ucr dashboard that my team's currently responsible for. I've only got 5 minutes, so it'll be a quick whiz through. As we've mentioned before, there are other dashboards out there. So I think Rob mentioned the data quality dashboard. There have been sessions on that. That's on the website. Although saying that, there have been some recent additions to this dashboard, which I'll just go through. But before I start talking about the dashboard, so why does this matter? So, as you'll know, the urgent community response has been a major policy initiative for community and has attracted some significant funding. The intention, I believe, is to give the 2-hour performance target a similar level of prominence that targets like the 4-hour A&E and 18-week wait for treatment have in the acute sector. So we've been monitoring the submission of data since the ability to record UCR in CSDS has existed since version 1.5 in July 2020. So firstly by the NHS England spreadsheet, which quite a few of you I'm sure will be familiar with, and now in this new dashboard. However, up until now, these products have only been released as management information to allow providers and commissioners to monitor their own data. As Isabel mentioned earlier, last week, NHS England Public released this, a subset of these measures on their website, and this did result in an article in the Health Service Journal focusing on regional differences in data coverage and the achievement of the 2-hour target. So it generated quite a few comments, including some saying that, locally they thought that their performance was better than shown in the data. So if you do see anything in the data that you think doesn't look right, it might be a data quality issue with your submission or interpretation issue of the policy, for example. So please do get in touch with either us in NHS Digital or NHS England if you see anything that doesn't look quite right. So generally, given what's happened recently, the spotlight on UCR data and the achievement of the target is only going to increase. This is UCR specific, but CSDS has, for a long time, it's been kind of a data set that hasn't had a huge amount of prominence compared to other large national data sets like maternity and probably more recently mental health, for example, or HES, long established and probably, the big brothers of community. But recently there has been a lot more interest in CSDS, not just UCR, but we've mentioned musculoskeletal. Also, weight management is going to come to the forefront quite soon. CSDS 1.6, the next version, is going to support the work on the national obesity audit. So it's getting a lot more prominence in a lot more different policy areas. So very quickly, I shall just run through the dashboard, and I'm sure some of you have seen this before. So this is a front page, the contents, the user guidance. Not planning to talk a huge amount about this. It just gives you some basic information about what's in the dashboard, how to navigate. The second page, user guidance, and this is the main sort of navigation page really. So you can select the month that you want to look at from the drop down. You select your organization type, so you can look at the national level data, provider level data, region and STP. You can also search, so it narrows down, it makes it a little bit more user friendly. Oops. Not without its quirks though. So the first data page is, I suppose, the headline measures really. So these are the UCR 2-hour standard referrals. So the number of those and the proportion that have passed or not passed the 2-hour standard. So we do get a lot of questions about what's the difference between the 2-hour standard and all UCR referrals. So these are just 0.5s. It excludes those that don't have a linked care contact. It excludes those that come from an acute setting, and excludes those where the patient either did not turn up or cancelled, because clearly it's not fair to assess whether or not the target has been met if the patient didn't turn up. You'll notice that there is a big yellow bar at the top here. That's to denote that the latest month in the dashboard is always going to be a provisional data month, which means that it will be refreshed in the next update session. Unfortunately, we're not able to make the same thing on a double stacked bar. It's one of those things that Power BI can't do at the moment. We have asked Microsoft to add this in. It's one of the things that's on their list. Power BI is kind of a work in progress. It's relatively new, and there are quite a few things that you can do quite easily in Excel, but you can't do in Power BI yet. Moving on to the next page. So this is all referrals. As you can see, there's a lot more of them because this doesn't exclude all the ones I've mentioned before. So we have a high level count of all crisis response referrals, a summary of the validity, and validity means basically that we have a fully recorded clock start and clock stop, and the weight is not negative. It also must have a linked care contact and not be excluded. We have a donut chart here showing the various different sources of referrals. We have had feedback that there's an awful lot going on there, so potentially that might be one we could tidy up, turn into a bar chart or something else. The one below that just shows the number of UCR referrals by service type, so primarily team type 51 crisis response is the vast majority of referrals. Moving on to the next one, this is a breakdown of UCR referrals by demographics. Not a huge amount to say on that really, so I shall just move on. Next one's care contacts. So we have care contacts by consultation medium, team type, and whether or not they attended, did not attend, cancelled, etc. The next page, care activity and care contact duration. So this is one of the new pages I mentioned earlier. We added this in last week. It's one of the measures that has been in existence in the NHS England spreadsheet version for quite some time, but we've been kind of slowly adding more and more measures to the dashboard over time, and this page is one of the new ones. We decided to add this in as a time series because it just gives more information really on trends over time. So potentially we could change more of the charts into time series if people think that's more useful. Next page is discharges and onward referrals. So again, this is a new one that wasn't in last week. You will notice that the number of home care discharges kind of extends a little bit into May, and this is due to the way that a small number of discharges kind of move over to the next month to allow for delays in I believe it's discharge letters. So in April's data, we'll always get a little bit of data for May. We could have excluded it, but we decided to keep it in. Standard chart showing the discharges by team type, which follows essentially the same pattern as the number of referrals by team type, and the number of onward referrals. Moving on to the next one. So this one shows the referrals that were rejected or received late. This is essentially more of a data quality page than anything else. And it has, as you can see, shown some quite interesting data with quite a large spike of late referrals that's appeared in summer last year. Again, if you're looking at a single month, you won't get this view, but looking at a time series, it does kind of give you some interesting trends. This one in particular was narrowed down to the Midlands region. I don't know whether or not it's one particular provider or a couple of particular providers, but clearly there was a data quality issue or a submission issue. Something went a little bit awry there, but since has been fixed and it's gone down to reasonably steady levels. Next one. And this just gives you a basic overview of, since the beginning of when we started collecting UCR data, how many providers have submitted. And again, you can look by region, provider, or you look at your STP. And that's basically it for the dashboard, apart from the final sheet, which just gives you a bit of metadata at the end on how each of the measures are created. So this is quite old. We are looking to revamp this a little bit. There are some new measures included in the dashboard that's not on there yet. We have been asked for some detailed descriptions, potentially sharing the code that we use to generate these measures so that other people can do this kind of thing locally and potentially sort of delve in greater detail. And we'll look to include those in future updates. So I think that's basically it. One thing probably worth mentioning is that we are also working on a split STP provider view. That's been probably the #1 on the shopping list for many people who fed back on the UCR dashboard. So, you know, I'm an STP and I want to take a look at, you know, how each of my individual providers are performing, or yeah, I'm a provider and I want to see the proportion from each STP. That's ongoing at the moment. We have done the data work and we're currently trying to fit that into the dashboard, so we've got a visual view. I can't give you an exact timescale on that, but we are actually currently working on it, so fingers crossed it should be fairly soon. And I think that's it. I think
Thanks very much,
I've gone
Giles.
over my 5 minutes.
You definitely have, but that's okay. I think it just shows the art of the possible as well. And as you can tell from what Giles has been saying, you know, it's changing pretty much every day, and it's based on the feedback that we get from you. So there really is this drive to make sure that it works. It's not just for the national team, it's absolutely for you to be able to make the most best use of it. Now I'm going to pass over to Dan now. This is the cool part of this webinar, and this is the really practical bit as well. So Dan has been absolutely amazing, along with the other colleagues in the data team, in supporting onboarding and registering and submitting data to CSDS. And so I'm really happy that he's agreed to come and do this session as well with us. And I'll pass over to you immediately, Dan. You go ahead, take it away.
Thanks, Isabel. Dan McCauley, I'm Data Liaison Manager for the South East region, but I've been working the last 6 or 9 months with the National Community Data Team supporting onboarding of community providers. In that time, I think there's probably been 40, 50 brand new submitters. So covering a whole spectrum, not just the UCR that Giles was talking about, but wheelchair services, orthotics, prosthetics, MSK providers, a whole range really. So they would be the sort of providers that, you know, could be on the call, are likely to be in scope for submitting. I've probably worked with similar providers, maybe with similar systems. So the idea of this is really to give kind of practical overview of how you would go about submitting. The thing with CSDS, and that kind of description gives a little bit of that, is CSDS is very broad. Lots of people approach it in very different ways with very different systems. So it's hard in a webinar to give that kind of provider level individual detail. Very happy after this though to, you know, cover any questions, to pick up individual provider calls, and to look more at individual circumstances, because this really is a very broad brush overview. So the first bit I've got really is, what is CSDS? It really starts at the top level. As Rob was saying earlier, it's a person level secondary uses collection. So it collects at the patient level data. It's different to what you might submit for, say, contract monitoring purposes. It's not target driven in that sense. You're submitting the patient data, the referral data, the activity data as you capture it. So it's secondary uses with the idea that it reuses data you're already collecting for clinical and operational purposes at a provider level. So why patient level? It's a much richer data set than you might otherwise have, and it is the main sort of national data set in the community space. So it's equivalent to sort of mental health data set, or CDS, the commissioning data set that hospitals or mental health providers would be submitting. So this is the big main equivalent in the community space. It being patient level, it lets you do a lot richer analysis on the pseudonymized aggregate data set. You can do the sort of things that are listed there on the screen in terms of sort of longitudinal analysis about patient journeys. You could ask, you know, questions about do patients over a certain age from certain ethnic backgrounds, say, have better outcomes. It's a really rich, useful data set for analysis, for policy, for planning purposes. The data is available for reuse by commissioners through our distro teams as well. So it isn't just a national thing, it is very much, you know, in restricted ways available for systems and for other people to reuse as well. So it's a very, very useful data set. It is also technically a legal requirement in contract terms as well. There's a little line about that on the end, but it is part of the standard NHS contracts. It has historically not been submitted to by as many providers, which is partly why the push at the moment, but we are making big progress on that. The next bit on here is just really what it collects. There's a little data model further on in this, and I've shared my desktop rather than just the slides because I wanted this to be a bit more of a practical demo, so I might switch between screens and sort of show what providers would actually be uploading, what the data set sort of looks like. But in essence, it's the person details, the patient details, the referral details, the care contact and care activity details, and then various bits branched off of that. The data model, if you're interested from a data point of view in such things, looks like that. So it's 37 tables, the main ones in the middle there being the person details, the yellow set, the blue's the referral, and the purple's the care contact. A lot of these things are contextual to certain services, so most providers wouldn't be submitting a lot of these tables. I know it looks on the face of it like a big lot of data. I think Isabel was saying about how previously, or maybe Freddie, that this was part of a children and young people's collection and an old SIDS collection, which was a sort of legacy community data set. So a lot of these things are specific, contextual to children's services, say. So you've got the things like immunisation, child protection plan, safeguarding. So there's a lot in there that are specific to certain services and then core other data items. So you really want to look at this as it is contextual to your service. Like I say, the idea is reusing what you capture locally. So the sort of general principle is if you record it within your system, you know, then if it maps to the data set, that's what you'd be returning. It's further on in the slides, but I'll probably say up front that some of the system suppliers do make CSD extracts available, so you wouldn't necessarily have to work through every data item, every table, and kind of work out, is this relevant to return or not? Some of the system suppliers will effectively do that for you, like the main kind of clinical systems, if you happen to have one, will standardly produce a CSDS data extract that will give you like a monthly file that you can then effectively just go and upload. It's a very different conversation with providers that don't have that. If you're constructing your own data extracts, your own data submissions. So with any providers in that sort of circumstance, that's where, you know, more of an individual provider level call is quite often useful, because we can discuss through, you know, how you'd approach extracting and collecting the data together to submit. In terms of how it would work, there's a monthly reporting period. So you submit, the basic inclusion criteria is active referrals. So say if it was the May reporting period, you'd submit the patient and the referral details for referrals that were active during May, and then any care contacts that happened in that period. And that just rolls forward. With CSDS, you've got a rolling sort of 2 monthly period of time that you can submit for. So at the moment in June, the providers would have been submitting May and April activity data, so care contacts that happened in April and May, and that's what on the screen there is called the primary and the refresh periods. So primary being the immediate prior month, So right now it would have been May, and the refresh is April. The refresh been, I suppose, a sort of second chance to submit, or an opportunity to resubmit. You know, if you found data quality issues, system issues, maybe you had some system downtime, someone was off, you could, in those cases, make a refresh submission. But primary is the main submission we'd be expecting from all providers. There's a link on the end there to the published data from Csds. As Charles was talking about, there are multiple other dashboards and ways that the data is reused, which I think quite a few are linked off of that link there for the stats publications. We'll share the slides after, so you can kind of dig into any of the links on here. Yeah, and that's just what I flashed over to on the other PDF page, but it gives a summary of the sort of information that's been collected. So yeah, if there is any queries about, I don't know, service specific, provider specific, inclusion, mapping, what does this mean for me? You can pick up any of that afterwards. I'll put my email address in the chat, but very happy to cover any individual queries. This is probably not relevant now to our UCR providers, because like Isabel said, 97% of those are submitting now. It could be relevant to 2-day UCR still. That is the reablement part of UCR. So I've left that in there. I don't think there are any providers on the calls in that kind of category looking down the list, but I can cover that in more detail, and I've got some specific UCR slides if it was useful for anyone. The main kind of go-to guidance for anyone starting on this is we've got online a step-by-step guidance. So it runs through each of these stages, which is a sort of end-to-end of how to submit. So it gives you that overview, and then registration. I've got some steps further down here, but registration, how to prepare your data. So the two options you have to make an upload of your data is either as an access file or an XML file. So there's some more details about both of those options. It talks about the supporting documentation, the information about the data set, the sort of inclusion criteria for what you need to send, and using the cloud portal, which is just our submission portal, which is SCDS Cloud. We've got quite a few front doors, but for these main data sets, for mental health, for IAPTs, for CSDS, for maternity, it's SCDS Cloud. So it's in common. If you submit to any of those other data sets, it would be in common with that. And the CDS Cloud gives you rejection and warning messages, so that takes you through that. So it's really the full sort of end-to-end, and does cover a lot of questions. There's some videos as well at the end there, so if you prefer I don't know, more visual presentation, there's some very short sort of useful videos that cover most of the main stages. So breaking that down in more detail, the overview bit I've kind of covered. That the registration, you really need 3 things to register and submit. You need an ODS code, which is an organizational code. It's usually 3 digits, depending. But yeah, there's a process at the link for registering for an ODS code if you don't already have one. Most providers do, because they'll use it for submitting to other data sets. And you need to have an IG lead registered for that ODS code. The reason being is because part of the governance process, the IG lead will send through to us the request form for new submitters. So the governance bit is really saying the IG lead approves you handling in PID, personal identifiable data, and sending it to us. So yeah, you'd fill out that DUC form, the DUC form, with your submitter details, and the IG lead would send it through to our service desk. Because it's PID data, the sort of security around that is there's a two-factor login for our portal for SCDS Cloud. So the link there will take you through how to set that up, how to activate it. The most common option is the Google Authenticator app. So you could install that on your own phone, but the function of it's really just to give you a 6-digit number. After your sort of username and password login on the portal, you'd press a button, it sends a link to your smartphone, you get the number and then put that in on the website for the portal. So it's just that extra security step. The key, aside from the step-by-step guidance, if you want to go into more detail, the 3 kind of key documentation bits of this, so those 3 links there, it's the data model, which is what I had on the screen looking like this. So it shows the different tables. It's a relational data set. So it's based on the data being in separate tables. So you've got patient details in one table, their referral details in another. It's on the assumption that patients can have multiple referrals and then multiple care contacts. So the structure allows for that. In terms of what you'll actually be submitting in the data, that's covered in more detail in the output spec, which is, it looks like this. So it's got a tab. The most of the content is a tab for each of the tables, each of the 37 tables. I'll go in a bit more detail about the key ones, but the basic structure of this is each of the tables have mandation, whether you have to include that table or not. So that's what this column up here is about. I'll say a bit more about that in a minute. So I've got a slide that covers that, but you'll find that for each of the tables. And then it lists down details for each of the fields. So what that field is, warning messages you can get against that field, descriptions of what the field is, the format is quite important because that's one of the validations. So say for patient identifier, it has to be alphanumeric up to 20 characters, which is what these are saying here for the format of them. A lot of them are coded fields. So ethnicity here is coded A through, well, to R and then skips. So it's following NHS data dictionary coding. So if you have kind of one of the more off-the-shelf clinical systems, it will most likely map to this or be called something very similar to this on the front end of the system, because they'll build it around NHS data dictionary definitions. If not, I can support with kind of mapping queries of for some of them anyway. What would this be if I call it this? I can cover, if anyone has queries about that. So that's the output spec. It really goes through in quite a lot of detail for each individual data item. The other third document is our user guidance for CSDS. So it's a PDF equivalent. It covers a lot of what's in the output spec, but gives it in a more descriptive way. It's more something you might read. And it gives answers to common queries as well. So if you're struggling with a kind of query about something, chances are it could be covered in here. So something people often ask is about GP codes. I don't know a GP code. The equivalent field in this for general practice medical code covers the defaults. So say unknown is V81999. So it'll give you things like that if you're struggling with, what do I put in this field? So they're the 3 kind of key things to reference. It's probably the step-by-step as a starting point, and then you can go into more detail in those 3 documents. as I say, EPR systems, a lot of the main EPR systems in the community space will do a CSDS extract. So an early thing I'd check is, does your system supplier, if you have one, do a CSDS extract? Do they support that? Because if they do, it will save a lot of the manual reporting, manual manipulation of the data. So that would be something I'd check early on. In terms of outputs, like a lot of those system suppliers will output as XML or CSV. If you were creating your own extracts, the two upload options are Access or XML. So very commonly you'd get like a zip file of CSVs, and then providers will populate the Access file with those CSVs. So that's going down the left is the 37 tables, and like most commonly you'd right click import and import text file it'd be if it was CSVs. So if you've got the data in that sort of format, it's fairly straightforward from that point. The step-by-step guidance, there's one of the steps in there is submitting your data as an Access file, and there's some links that cover how to import your data to Access and covers common queries. This is all just sample data, but various times I've been demoing how to populate the Access file. I've imported the same data again, as you can see, but that's an idea of what it would look like. In terms of the XML, it's probably a more like 70%-ish, 70-80% of people submit with Access. It's really a lot more human kind of readable. You can open it, you can see a list of patients. You can more visually sort of inspect it. The XML is probably more where people have data warehouses, data teams, where they've got more capacity to generate XML. More resource to do that, but yeah, it's a similar. This is a sample file, but the XML schema and the various diagrams I can share if anyone's thinking about that. The basic structure is a header table, and then the patient records, and then nested within that the referral and the care contact details with various bits underneath. But yeah, we've had, I don't know, maybe half a dozen, 10 recent new submitters with XML. So, and they've all, gone through to submission, first submission. So I can certainly help in the same way with anyone who's considering that. The link there takes you to some screenshots of what SCDS Cloud would look like. So our submission portal looks something like this. So you'd go in, submit a file, you'd select your organization, you'd CSDS as the collection. Reporting period would be, say, May for the last one. There is a function in that little checkbox there to do a test submission. So if you were sort of working up to do first time submission, you could tick that and then upload your file. You'd get the same validation error and warning files back, excuse me, as you would if it was a live submission, but the data wouldn't come through to us for analysis. So you can use it to sort of test the data, test your files prior to live submission. And the last bit there is you just go and select your file, upload. It runs through some checks. This is what's going on there, and then you've got a dashboard. If you click through on the right, it's where it takes you through to dashboard for the submission. So that's submitted records, rejected records, accepted records, and any that are rejected. The following page here takes you through the sort of messages that you'd get back. So you get a little coded message that will say something like, it's usually like format isn't what was expected. You've got a date where a number's due, or if you miss, say, like a leading 0 off an 01 code, that's quite common. like postcodes with zeros where O's are expected, that sort of thing. Dates that are out of the date range as well. So if you're reporting for May and you submit, I don't know, a care contact from last year or referrals that are out of the sort of expected range, things like that would be the validation messages. So that's there, and we can help, you know, interpreting any of the sort of errors, validations that you get back. Our csds.dq@nhs.net team, our DQ team, it would commonly kind of support with issues like that as they come up. So sort of running into beyond that, that's really all of the guidance. In terms of, I was showing in the output spec that certain fields are mandatory, some are required. And they're the main two categories of mandation. So you always have to have the mandatory tables and fields. It's really, people kind of confuse this, I guess, but it's very specifically a technical definition of mandatory. So it is essentially what you need in your file to pass validation on the portal. So it's not saying something like a wheelchair service has to have these data items, because you'd have to have a lot more than just the mandatory tables and fields there. It's really just what you have to have in terms of the data in your file to pass the validation on the portal. So the three mandatory tables, the header, the MPI, GP registration. The header table is really just the metadata for your submission. So it's saying who you are and what you're submitting. So it's always just one record, like is on screen there. It's CSDS 1.5, your ODS code, the reporting period you're submitting for. And you always have to have that in every file. And then just so it makes sense as a file, you need to have some patient details in there. So the MPI and the GP are the mandatory other tables. So you've got a header table and you've got some content, and that is all it is, purely mandatory for the tables. Beyond that, it switches on with the required. I could show it better on here, but if you see the MPI table in the output spec will say M at the top, because that's a mandatory field. So you have to have that table and then any mandatory fields within that table. So that's the ID, the your ODS code that field is. They're also the ones that are bold on the data model. If you were looking at this, you can see these bold lines fields here are also the mandatory ones, if you wanted to look at it like that. The other tables, which these tabs sort of represent, become mandatory if you put anything in them. So it says required here, because technically you could leave it blank and submit a file, but as soon as you put anything in it, the fields within that table that are mandatory, the sort of mandation gets switched on. So if you put anything in the referral table, you'd have to have you know, the referral request receipt date. You'd have to have the commissioner ODS code, which that one is. It's mandatory because it's the kind of key thing for our reporting. So I don't know if there probably are CCGs on the call, but in terms of our feeds that get split out and go to commissioners, it's that field that would drive that. So they're ones you always have to have. Beyond that, we're often asked, you know, what do I have to submit? You know, if I'm kind of creating my own submission, if I don't have a system extract that's built for me, what do I need to submit? There isn't really service specific guidance, so I guess this is here, and it was in a DQ webinar we did before, but it's a kind of, I guess, base or a starting point for looking at core fields, core tables, and then building onto that anything that's sort of contextually relevant for your service. So it's looking at, you know, referral details, care contact details, and that's really the core of the data set. It's that patient journey, that patient pathway. So it's kind of making sure that that's in there to reflect the activity. Beyond that, because this is really just a very broad overview, it's just listing out in a sort of summary way the guidance that's there and some other useful links. So I've got the step-by-step guidance, those 3 other documents. There's a whole section about IG. So if you've got, as a new submitter, IG queries, they're all, and if you want to reproduce some of that for local DPIAs or otherwise, that's a lot of that's available at the IG page there. Csds Cloud, that's our portal. There's some guidance for the portal. Ucr Dashboard that was mentioned before. The ISN is what we issue to make the Csds legally required under the Health and Social Care Act. So that link there is just to that ISN document that we issue. It's got some of the kind of data set background, some of the legal wording if you wanted to reuse that, I guess particularly for the IG purposes, for why you need to send us that data. This is probably quite out of date now because we've done, I'm sure, more webinars since, but if you follow through that last link, it's got more recent webinars. There's been some on DQ, some other ones, I'm sure. We've got a monthly newsletter as well. So if you are looking, once you get into submission, if you want to know, about data set changes, about, latest sort of national system priorities, a lot of that will be covered in the newsletter. So definitely as a submitter, you'd want to sign up to that, and then just contact emails on the end there. I did want to leave quite a bit of time for questions if anyone has them, and I think I'm due up until about 10 past for my slot. So I don't know if there's any questions in the chat that haven't been covered, or if anyone wants to otherwise shout up or add things into the chat.
Thanks very much, Dan. And yeah, there are a couple of questions, and there are some questions that I've picked up from some ICS colleagues as well. So one of them is, can a member of the CCG or ICB team have access to the CSDS dataset to run reports? And I know that Claire's responded on what they've done in South West London, but I don't know whether you've got anything to add to that.
That might just be what Giles has answered. It looks like a similar query,
yeah,
but yeah, the our Distro teams, data services for commissioning regional offices, I think the acronym stands for. But as I understand the process anyway, our Distro teams will produce a commissioner extract for specific commissioners for their data that's for services they've commissioned. They'll produce the CSDS extract that covers those in a kind of agreed format. There are, I think, schemas for that and some guidance online that I could share for a bit more detail. But yeah, there's an email address there in the chat.
Yeah.
But yeah, I think if you speak to your sort of BI type data team at the CCG, I'm sure that'd be something they'd be familiar with and used to working with. Okay,
thank you very much. And then there's another one. Peter asks, which service types are in scope?
There's a list, a handy list at the end of the user guidance here, which is most often where I reference it, but it's what feeds the 102 table in the data set. You have to put what type of service you're submitting for, and with that there's this list of in-scope services. So hopefully this would relate to one that you'd recognise your own service as being. Sort of common ones on here that I've worked with would be not sure, say end of life care, health visiting, school nursing, MSK is quite common, nutrition, dietetics, physiotherapy as well, a few, rehabilitation,
And there's certainly some priorities for the national team. So UCR was obviously the first priority. And then I think MSK, we've been seeing some really long waiting times. So that may be one that we might want to prioritise maybe for London region as well. And yes, so whatever's in the national priority list. So we'll definitely be looking at waiting times, but I'm not quite sure within which services. So certainly have a look at that list, and what we can do is produce a Q&A document with some key questions, and then we'll add the answers, and we can share that around as well. So I don't know if there's any more questions from the group or anything that anybody would like to ask. I think that's covered what was in the chat.
So Isabel, it's Giles here. I just want to kind of cover the service question.
So go ahead.
It's it's a list that's been around for a long time, and we recognise that there might be some services that aren't specifically listed there. So in general, the principle is if you are a community provider and you are providing a community service that's publicly funded, so not necessarily just NHS but local authority, and you are receiving money for a community service, then you should be submitting to CSDS. And if none of these service lines apply to you, then although we don't like to encourage people just to default to the usual other, we'd like to know about your activity, even if it's not under one of these specific services.
Thank you very much, Giles. We've got a couple of questions. So Paul.
Hello there. Yes, it's regarding our data quality mainly. It's because we're trying to provide as much accurate data as we can, and we're experiencing things like where GPs, like local GPs, have closed, and they're now fall within umbrella GPs, and we're receiving referrals from those GPs. And when we put them into our system, they don't really match up with what the NHS says, because the NHS says that they're closed. Is there some way that we can find out where patients have actually gone to as well? Because we've got a lot of legacy data where these GPs have closed and we don't know where they've gone. We might have information like the NHS number, and obviously we got their address. But is there any way we can access data so that we can update our data to make sure we give you the best quality?
I guess there's 2 or 3 things on that. Like there's a function called NHS Spine that would, if you've got like a spine enabled system, it would pull through basic patient details into your EPR records. So that potentially could update through that. I could share some information on that afterwards. In terms of ODS codes themselves, like a GP's closed as CCG's changed its name, which is quite relevant at the moment, I suppose. There's various ways of accessing our ODS data, which is where that comes from, what you'd be populating those fields with. There's things like an API that would update as and when there are changes, if you can access that. And there's sort of bulk file download options as well, and there's a web search function. So there's various ways of kind of accessing the ODS data depending what you can kind of set up locally for your system. So I've put a link to the ODS.
And we'd be able to use that. We'd be able to use that to pull in client data, would we?
It would just be purely for the ODS side. The NHS Spine would be on the basic sort of patient details side. Depends what system you've got, but I can, like I say, share a bit more on that afterwards. And otherwise you would just be putting the default for the GP code, which isn't so uncommon. Those the kind of 1999 codes, but it's really kind of you're returning the best data you have. We do cross-check it against what we have nationally as well, so we can cover for gaps, and I guess that's particularly Giles's bit actually, but yeah, it's really kind of best efforts, I guess, with what you can return. But
Yeah,
I know
yeah.
particularly non-NHS trust providers would have access to, sometimes quite limited data, and we do recognise that.
Yeah, that'd be us.
Mm.
I would have thought wheelchair service.
Yeah.
Yeah.
Thank you.
Okay. Okay. Thank you.
Hope that's helpful. Okay, Claire, thanks for putting your hand up.
No worries. I've got a couple of questions, if you don't mind.
Yeah,
So
go for it.
The first one was around organisations that are only part funded by NHS, and perhaps the other half is charity funded. Would the activity that they submit, because I presume they wouldn't be able to purely attach a piece of activity to just NHS, it would just be it's been funded in one way or the other. So would they therefore need to submit all of their activity?
It really depends. Like, the legal mandation is on publicly funded services, NHS, local authority funded services, community services. Beyond that, I guess ideally they could look at how the data is recorded. I'm not sure about, say, like private provision, because it had come into IG questions potentially about sharing that data. I could come back to you about that sort of scenario, unless any of my colleagues on the call can pick it up. But yeah, most providers we speak to are of, NHS publicly funded services, so that wouldn't usually be a factor for them.
I think the question has come up in London because there are quite a few services that are NHS funded, but they also provide non-NHS funded services. And I guess the challenge is that submitting parts of that data is more challenging than submitting all of it and all of the services they cover. And certainly on a regional level, what we want to know is what services are being provided to our population as a whole, whether they're NHS funded or not. So ultimately we'd want to get to that stage, but I don't know whether how we would get there. Presumably there'd be some kind of marker that marks the those services that are maybe not funded, but at least having that visibility. Otherwise the use of the data will maybe be not so useful, I'm guessing. Okay, there's another hand up and I can't see who it is. Somebody put their hand up and put it down again?
I had a second question. Sorry.
Oh, okay, sorry, go ahead.
My other question was around the team types, because in working with some of our providers in South West London, there are some services that they run that haven't got a specific team type. One off the top of my head is the full service, for example, and so they're being grouped under other different services depending on which provider you talk to. So is there some scope for amending or adding to the service line so that we can tease out some of these services?
Like, one of the things that the data set goes through is periodic updates. So yeah, certainly there is consultation, fairly frequently about what do people want in the next data set version. Our data set development team would run that. So can certainly share, for things that, if people think are missing, some way the data set, doesn't reflect that, that service type, if they can't accurately reflect their activity in the data set, things like that would commonly come up, changes in clinical practice, things that are kind of new for the coded lists or for sources. So yeah, definitely for any ideas on that. I think elsewhere, false services have often come up with reablement providers, because it's part of that. Someone's fallen in their home, we're going to go and support them in that home setting. So I think where I've seen it elsewhere, falls has come under the home-based reablement, like the 53 code, but there is quite often a bit of interpretation with that.
For some services, it's the district nurses, so it kind of
Yeah, I think the policy team in NHS England are currently working with our dataset development team on some of the things that you've mentioned. So if there are any specifics in London, I'd probably send them to Rob in NHS England who'd probably be able to send it on to the right person. I can't remember the name of the person who's leading on this service line redesign at the moment, but I'm sure Rob will be able to point it in the right direction.
Yeah, thanks, Giles and Claire, and thanks for raising this. I mean, it is something we've also had feedback from, about the services as described in CSDS, and we know they do need updating, they do need refreshing. So there's a colleague of mine, Jill Thornton, who is working with colleagues at NHSD to review that. And I think as Dan mentioned, periodically, there will be a refresh to the data set, and I think we are looking at the services as described, because you'll see from the list in the service guidance some of the language is a little bit dated for some of them. They're not necessarily reflective of services on the ground. So yeah, thanks. Any suggestions? I'll put my email in the chat too. So any feedback regarding those would be really appreciated. Thanks.
That's great. That's really helpful. Thank you.
Thank you.
Great, thanks very much. And Shahzad, I know you had your hand up. I don't know if you're still itching to ask a question.
No, it wasn't a question. I think when I think Claire was asking about the private patient, if the patients they are private funded. What I believe, I think when you are getting a patient on a private, like if they are a private, they have a different pathway. They don't come under this coding. There must be a code for that referral. And I don't think so. They will be classed in this data.
Right. Okay. Are you part of the Southwest London?
No. I work within North Central London CCG.
Right. Okay. So that's probably something best to pick up with Shafiq, I imagine, to just iron out to see where that's being captured.
Yeah, I will. Definitely. I think there's a code for, as far as I know, anything to do with the private. I think it's not part of any of the waiting times. They are not on any pathway. So once we put the code for the private patient, that's it. They are out of this data. That's what I know.
I think that's correct, but I think there was some activity where it's not necessarily a patient is either private or NHS funded. It's that the organisation is funded in part by charity. So that's
right. Yeah. And ultimately where we're trying to get to is that visibility of all the services. But yes, we are, and that's maybe part of the longer journey. So there was one more question that I wanted to ask, which was a number of organisations are getting EPR funding, and so they're maybe setting up a new EPR system, or in the process of rolling one out, or they're updating it, which may make them want to not necessarily register or submit data. Is there anything that they can do as a starter for 10, while this is happening? Because there's obviously no point in starting to submit data and going through the whole process, only to redo the process when the new PR system is in place.
We have actually quite a few of those nationally, maybe 5, 6 of them who are going through a similar sort of transition process at the moment. And it's that thing of, it's a very big thing transitioning EPRs, and kind of trying to submit from one EPR for a couple of months and then move into another EPR. There's maybe not that much utility purpose in doing that. I guess it's just kind of speaking to the provider about where they're at, but we do have a kind of flag. The main way we're monitoring it is expected first submission. So it's really, can we work with the provider to understand where they're at and then pick up once they are able to submit. The new EPR might really help, them get off the ground with a good submission. Making sure that new EPR is kind of compliant with CSDS as well, if it kind of fits with what they'll be submitting, is a big part of that. So I guess that is one thing. It's like looking at, how they plan to use the EPR. Will the sort of stuff they're recording on the front end, will it map to CSDS? Does the system supplier support CSDS extracts and submissions? They'd be kind of big things. But yeah, in the meantime, they could register for SCDS Cloud. We could work through with them any queries. They could, work with their staff about the sort of the things that need to be recording on the front end and why. And yeah, there's still lots of kind of groundwork potentially, leading towards
data quality,
first submission.
Yeah, working on the data and which data sets to submit, I'm guessing, and and maybe making sure that that data is ready to be submitted. And registering, I guess, do you need to have your new PR system in place in order to register, or can you register now?
At any point, yeah. You do I think get cut off of the portal if you haven't logged in something like 6 months. So maybe if it's longer than that, probably not.
Yeah.
But yeah, if it's kind of imminent, then yeah, go ahead and register as soon as.
That's a really good point to end on, and we're just getting to the close of this meeting. Thank you very, very much to all of our speakers. You've been absolutely fantastic. And if there's one thing I'd like to leave you with is just register, because once you've registered, we can take it. That's the first step, and you've got all the information there. There is absolutely loads of support available, whether it's a one-to-one or part of a general webinar that's produced by the national team, or this webinar. And we'd really like to understand more about and get that relationship between the London regional team and provider organisations. And we're going to be working with our community and digital leads to work a bit better with you, so that we're much clearer and have a better understanding of what your challenges are, and then with the aim of pointing you to resources when they become available, because the national team is absolutely really supportive in lots of different aspects of this, and there are likely to be resources available to be able to improve our data quality and data submission, and just having that visibility of our community services across London. So thank you very much. We've got 2 minutes to spare. Thank you for your engagement. Thank you for your questions. We'll pull together all the documentation and send that over to the members of this webinar, and the information will also be available on our future NHS page that Kura will also send the link for that. So thank you very much and have a really good afternoon.